I'm particularly happy this morning to see Representative Gentile here with us, a stalwart supporter of this work. And, you know, I had the opportunity this morning earlier to be doing some national training program, and I was talking with them about what I say so often here, which is so much that we have accomplished here is just really due to these partnerships. It is due to our legislative leaders, our law enforcement partners, those out in the field doing the work, the public health officials just continuing to come together every month, whether it's 100 degrees or we're in a snowstorm, and really share information and be always thinking about how are we doing it. And that is really how we've accomplished so much here. And, you know, folks who are regulars at the program know that I always begin by talking about where we are, keeping in mind that we use numbers to measure what's happened, but that numbers certainly don't tell the story. And when we talk about opioid deaths that we've experienced in the county, and we use a very conservative number, it isn't just the person who's lost their life, but if you take the idea that that person's death impacted maybe 10 people, when we know it's usually much more than that, suddenly that number is much bigger. And conversely, when we look at the progress we've made and how things are going, you know that we have impacted not just the people whose lives have been saved, but so many of their family members. I'm really happy with the fact that this year, comparing January 1st of 2024 to July 3rd of 2024, to that same time period this year, we saw a 37% decrease. So that's over a third decrease in fatal opioid overdoses. And for those of you who've been with us for a long time, you'll remember that for a stretch, probably about a 4-year stretch when we began this work, no matter how much time, talent, and treasure we were giving to the work, we could not turn those numbers around. We just couldn't. And to be in this place now, obviously one death is too many, but it really is remarkable and speaks to the level of work. I am particularly pleased. You know, one of the challenges we've been facing in the last year and a half is while we've seen the steady decline in our opioid overdose deaths, we have seen an increase in suicides through the use of opioids. But this month, we have seen a 66% reduction. So 2/3 reduction in the number of deaths by suicide where opioids were used. And remember, we classify that very stringently. We don't call a death by suicide unless we've got just incredibly clear information, a node, conversations, that kind of thing. But a 66% reduction in that is really a testament to work. And it is the same pattern because for the last year and a half, we've been devoting a lot of resources to that, and yet we've continued to see that number grow at somewhat of a frightening pace. So it's my hope that this is the beginning of a repetition of the same trend going in the other direction. And I'm sure that many of you saw that the Bureau of Substance Addiction Services last week reported that really in a great turn. The state is right about where we are now. They're at 36% statewide in the reduction of deaths. And Sarah Ruiz is going to talk to us a little bit more about that. And you know as well that over the last year, we've talked about a number of different groups and the particular challenges that they face in dealing with opioid addiction. And we've talked about pregnant women, construction workers. We were part of the stand down at Mass General a couple of months ago, and veterans. And today we also want to explore another group, and that is older adults. And that's something that is particularly important to me because for about 15 years before I was the DA, I spent a lot of time working on our cases where victims were either over the age of 60 or suffered from a physical disability. So that is a group that I've seen very firsthand, and it is a group that I think not everyone thinks about. Over the last few months, the Globe, the New York Times, the Wall Street Journal, and other sources have been talking about this sort of quiet problem. The stereotypes just don't include people over the age of 60 when you think about who's using drugs, who's dying from a drug overdose. But the people over the age of 60 are also the largest users of opioid painkillers across the population of the United States. So it makes sense. Many of these adults are taking them for chronic pain or following a major surgery. And we all know that it's that kind of exposure that can often lead to a problem and developing an addiction. Our grandparents program that we run in our office really recognizes this issue and speaks to people about managing and disposing of their medication, the signs that a problem is being developed, and where to head for treatment. And, according to the Substance Use and Mental Health Services Administration, and this is really a staggering number, 3.2 million people over the age of 60 in the United States in 2022, and that number's only gotten bigger, were suffering from a severe opioid addiction. So those 3.2 million people, are hiding in plain sight. And last year, so far this year, 29% of those opioid overdose deaths that we've responded to, so 29% of them, almost a third, are people over the age of 55. And that, when we say that to people, or when we pull those numbers and look at them, that's not at all what they're expecting. And last year we averaged out 39% of our people who had experienced an overdose death were over the age of 55. So we are somewhat below that, fortunately, this year, but remember, all of our numbers are down. So you'd expect to see that. Some of them have been using drugs for decades. Some are, as I mentioned, people who may have been introduced as a result of their pain or a surgery. And they really are folks, and I know Cassie's going to talk a little bit about this, are people who are often ignored or undertreated by the medical society. We all know prescribers, unless they've been educated around this issue, don't have the same reaction to handing a prescription to a 70-year-old that they would to a 25-year-old. They're not asking those same questions. We go into homes, to nursing home patients, and see just literally hundreds and hundreds of opioids. They have lots of medical contact. There's a reason for giving opioids for lots of conditions. And it really is something that we have not been effectively addressing. The Globe did an investigation this year finding that older Black men have been particularly affected. The data from the Department of Public Health, and Mike certainly knows this in Massachusetts, shows that while men of all ages suffering an overdose, those numbers have declined. In Black men over the age of 55, it has increased. So Black men over the age of 55 between 2017 and 2023 had a 242% increase in suffering an overdose. So people are aging into that group. We know that many of those individuals are coming out of an incarcerated setting. They may have been in a situation where they were using drugs before. One of the things we've been addressing is older prisoners and the use of K2, which is incredibly dangerous. But it is really a significant issue now in both our county houses of correction and the DOC facilities. And it tends to be older men who are using that substance. Of course, when they come out, unless they've gotten some treatment, they're going to be looking for something on the street. And another piece of it is that many of the men that we're talking about started using cocaine or other stimulants. They may still be using those, and they are reluctant to be seeking treatment. So because of their drug of choice, if you will, or the drug they use most consistently is not what much of our treatment is focused on. And keep in mind, the benefit of Narcan, so many more people are surviving an overdose. In Middlesex County so far this year, in over 40% of the overdoses that folks are responding to, a dose of Narcan has already been given by someone else, a family member, a bystander, somebody else, before medical help gets there. So, and we know that works. People are surviving, people are living longer. And that also means, though, in terms of our healthcare system, which we all know is already overloaded, if you are living with an addiction, you're living longer, that is taking a toll on your body. So we've got lots of people suffering from hepatitis or other kinds of side effects of many, many years of drug use. And Cassie's going to talk with us a little bit more about that issue. Now, I'm hoping we were going to begin with Sarah, but she's here. Sarah is here. All right, great.
Yes.
And Sarah Ruiz is the Deputy Director of Strategy and Community Health for the Department of Public Health Bureau of Substance Abuse Addiction Services, BSAS. And her division of the Bureau includes a wide range of areas. She covers primary prevention, community engagement and equity, and data and evaluation, harm reduction, recovery support, strategy, and innovation. She's been with BSAS for more than 25 years and happily is a resident of Middlesex County. So Sarah's joining us today to break down some of that recent statewide data that I referenced and provide some of the updates about what our financial changes in many, many programs are going to look like. So Sarah, thanks for being here with us.
Thank you, DA Ryan. It's great. Thank you for reaching out to BSAS. I'm happy to be here to really represent our director, Calvert, who's off this week, and bring presentation that she shared with the Public Health Council. It's good to see some familiar faces and names here. Good morning. It's great to be here to share an update from BSAS. Fortunately, it does not include a real breakdown in the data. At this point, it's pretty high level, but I'm interested in the updates the DA was just giving, and happy to sort of have more of that conversation. So I'm going to share what I'm doing today is last week, our director, Dee Calvert, gave an update to the Public Health Council, which some of the elements of that were elevated in the news and the State House news. And so we wanted to I'm going to share the same presentation that she shared for our Public Health Council. And let me just pull it up. Let's see. Let's see. Hopefully I believe I pulled up my my slides. Let's see, where are they here? Oops. Sorry, I can't see. Here we go. Okay, here we go. We're getting there. Okay. Still labeled as being with our director. Huh. I don't see them, do you? No. Now, why did I share the slides and now I'm seeing a blank screen? That is strange. Now, why is that? Come on, slides. Can you see that now?
Yep.
Now let's try this. When I hit, looks like when I hit, I guess I'll just skip. When I do like slideshow, it seems to disappear, even though I just did share screen. So that's all right. I guess we'll just go like this. Okay, I assume most of you are familiar with the Bureau of Substance Addiction Services, but we started off with introducing ourselves as the single state authority for substance use in Massachusetts, which means that we develop and implement, oversee prevention, treatment, harm reduction, recovery support throughout the Commonwealth. And we also provide training, technical assistance, the workforce, and at our core, we promote non-punitive approaches to substance use and support self-directed engagement as much as we can. We are like to start off also by laying the groundwork of our mission and vision, which is to support accessible, effective, and culturally responsive prevention, intervention, treatment, harm reduction, recovery support principles, programs, and practices. And our vision is a commonwealth that supports health and wellness for every individual, family, and community through effective efforts to prevent and address the harms of substance use and addiction. This is from a Recovery Day March that with Mass Organization of Addiction Recovery organizes, and there's several of our staff in this photos. We did jump right into talking about sort of the heartwarming, the trends that we'd see in our overdose data from 2024. We always want to acknowledge that we present aggregate numbers, but each one of these is an individual, it's a valued individual and member of our community. And with all due respect, we talk about these fatalities in aggregate numbers, but acknowledging the individuality of each person. So we mostly were sharing at this meeting the numbers that have been put out by the CDC. This is their, which they do take information from our vital records. So this is information that comes from Massachusetts. They apply some finalization to the numbers in terms of estimates, but they're putting out that in 2024, Massachusetts experienced 36.3% decrease in opiate-related overdose deaths, which is tremendous success for all of us, all of our efforts, joint efforts across the Commonwealth with different roles. And we want to always thank our partners and providers and the success that we're seeing. We didn't go into, we do acknowledge that this decrease is seen across race and ethnicity. So that is great. It is not, in the past, we had decreases in the white non-Hispanic population while there was ongoing increases in Black and Hispanic populations. This decrease is seen across all race and ethnicity. So that's encouraging. We then went on to show our image from our BSAS data dashboard. I hope, and there's a link there, and we'll be happy to share the slides, but hope many of you have had the opportunity to see our dashboard. It is available at the local level of a county and town and statewide levels that to be sorted. This is showing you can see here that you can click on different sets of information. This is just an image, but it's showing that you can have all substance-related deaths and look at that data. This is opioid-related overdose deaths. And then we have some information related to overdose death circumstances that can be reviewed on our dashboard. And like we said, at different increments within the state. So here we're also, with this data is, we put like the final confirmed deaths. And so we don't have we don't use the estimation that the CDC uses to put it out, but in the fall, we'll have sort of the final numbers here posted for 2024, but we're showing the same decrease in the first half of the 2024. We also show the substances present on the dashboard for the cases that have toxicology. We have show here that it's 88% that have the toxicology screen available. So not all, but majority. And then within that subset of all of these deaths, we can show what substances were present, right? So clearly it continues to be fentanyl being the primary driver. We do see this increasing presence in cocaine. And we always also point out that we began to document and the presence of xylazine which we'll say more about. And there's recently a state launched the Xylazine Commission, and we're sort of looking at the impact of xylazine and other contaminants in the drug supply. There has been, we believe, in this time period also, to the DA's comments earlier about the rise in Black men, older Black men with histories of cocaine use, that also would have in our drug checking programs seen at one time quite a bit of cocaine that was contaminated with fentanyl. So there was a lot of that. That seems to have improved from our drug checking activities. So hopefully that will help improve in terms of some of those unintentional deaths. Of course, all of these are considered unintentional. So I encourage you to check out our data dashboard. It has also treatment admissions and lots of other substance use related data is available there. So we had this from our International Overdose Awareness Day celebrations. We just again wanted to thank everybody's role and partnership in the success we saw in 2024. And we will be out again at the end of August for August 29th. I believe we'll be out planting flags again to acknowledge the lives lost. So encourage folks to swing by or to participate. So we're moving into a section where we talk about the financial situation at BSAS. They celebrate that the investments in substance use prevention, treatment, recovery, and harm reduction work, that we've seen these successes. And we will go through, I'm going to have a little update from each of these domains of our work as part of this. And but first, in terms of our financials, that of course we have this, I don't want to show my comments there. So this is just here's our high level budget of BSAS in looking at fiscal 2025. We had a total of $392.8 million for all of our operations and services that we fund. Our state total is here at 206 million. And then we point out that of that, there's really 111 million available to us for responding and sort of directing ourselves, because there is a lot of significant number of legislative earmarks, as well as other programmatic earmarks. And there's a cost sharing agreement we have with Mass Health related to residential treatment that requires us to give them $65 million. So out of this total, we ultimately have 111 from the state for all of our programming and operations. We have also, coincidentally, 111 million from federal funding, which is the major chunks are our substance use block grant, which has a requirement of 20% for primary prevention and some other requirements, but otherwise is there to provide infrastructure to the states. And our other major grant, I'm sure you're aware of, the state opioid response grant, the SOAR grant, is about 59.5 million. We had COVID ARPA money in this time period that now has been exhausted. So we have some restriction happening from that. You expand to spend that money, and then there's a restriction when it's done, as I'm sure you're all aware. And we also have had other reductions on our state appropriation. So there's like some restriction happening now related to the ending of some of these things and some reduction in state investment from previous years. So that's why we have less funding in some of our activities this year. And the final bucket being interagency service agreements, which we also give money in interagency service agreements, but in terms of our total allotments, this includes funding that comes from other parts of the state, and the state funds that transfer across agencies, and this is how we get our opioid remediation funding that we're assigned to disperse from the state portion of the opioid remediation funds. As you all know, municipalities get funding directly, and then there's a state pot, which is 60% of our total opioid remediation funding, and we get the annual portions based on the budget that's agreed upon with the opioid remediation fund council, and it's directed by EHS, or Executive Office of Health and Human Services. So they send us that portion, so which is designated by the council, and is responsive, obviously, to the needs of that. We will talk more about how we're spending some of those funds. So as far as that is the landscape of our funding. What has been challenging and was picked up some in State House News and news from this presentation is that we function as the payer of last resort for substance use disorder treatment, which means someone who's indigent, underserved, uninsured, or underinsured. So there's not other coverage. Our treatment and service providers are required to bill insurance as much as to the maximum possibility for their treatment services. If there's somebody is uninsured, or the insurance doesn't cover particular service, or that we work with insurance and Mass Health and other insurers to cover as much as possible, but we then can or agencies have contracts with us to cover what's called payer of last resort. If there's no other source, then BSAS covers it. Now the demand on this has increased substantially over the years, right? So now it's like we have greater and greater payer of last resort demands, and it's not fully funded. We're not funded like an entitlement, right? We don't just get money to cover this. So within those appropriations that I just described in the previous slide, we're using greater and greater chunks to cover payer of last resort treatment reimbursement. But we're having funding reductions, but meanwhile, and in part because a large part of it for us in terms of the expansion is driven by Section 35. There's been increases in the number of individuals who are sectioned, plus the way that Section 35 is reimbursed, and the issues related to coverage for that. We're estimated to pay $15 million in fiscal 25 just for Section 35 payer of last resort. So this is where we're starting to bump up on that the challenges with the restrictions in some of our appropriations, and the realities related to the ending of some funding sources naturally, and then the increases in the demand and payer last resort. So we're not it's been very challenging to meet that demand. And now with potential Medicaid cuts that will likely cause individuals to lose insurance, and then this is only expected to increase, as well as some of payer last resort in the past has been used often by people who some people who are uninsured, or people who are also undocumented. They're not eligible for Mass Health. They may be living here for many years, need to access substance use treatment, and then that falls to payer of last resort. But now there's a lot happening related to immigration status and payments, and so that is also going to be an ongoing issue related to just coverage for people who need treatment, and just legally how that is going to roll out in the next months, as well as just people being able to stay on Medicaid, of course, being a challenge as far as coverage for care. So this is the financial issue that we were taking the opportunity to elevate to the Public Health Council, to let them know that this is a financial challenge that BSAS is facing. Then we moved into an update on our primary prevention work. So I'm sure you all are aware that we fund upstream evidence-informed strategies through local communities. We fund programs across 200 municipalities that provide statewide infrastructure for primary prevention. And we also provide some training and capacity building related to for primary prevention. We so in addition to funding infrastructure and coalitions across the state, we also have a set of funding that's focused on sort of upstream prevention and with early childhood, the prevention and early childhood work, which we're excited about, really trying to go more and more upstream to tackle this challenge in the Commonwealth, right? Like, how can we really get more upstream and more at root causes and work on that early childhood development work? Where we are in our prevention work, really shifting towards a strength-based focus on promotion of positive childhood experiences. There's evidence which for them to counterbalance adverse childhood experiences and build resilience, right? Often we can't stop the adverse childhood experiences, or we can't, or once we are encountering, or they've already occurred, but we can build opportunities and structures in our communities that support positive childhood experiences and support building resilience. So despite the adverse events that inevitably often happen. So a model that we're excited about now is called the HOPE model, which is healthy outcomes from positive experiences. And so we've been digging in on with this, comes out of Tufts University. The evidence is built on the evidence of like what is preventative, like what are these positive childhood experiences in that have evidence to build resilience, and they fall into these buckets: the relationships, environment, engagement, and emotional growth. Without going into detail, we're really looking at how do we work with communities and partners to sort of boost these four building blocks so that we can build resilience in our communities and our young people. So we're excited about that because it's like, what are we aiming for? Not just like we're trying to, we don't want substance use and we don't want this, we don't want that. It's like, no, we want these things, right? We want safe and supportive relationships. We want safe environments. And we want social and civic engagement and meaning and connection to the community. We want opportunities for emotional growth. So we can build these things, right? So it's this is a model where we're promoting statewide and are digging in on. So as far as in the world of harm reduction, because harm reduction has often been under attack historically and nationally, but we really stand by the importance of meeting people where they're at and supporting their needs and reducing stigma and engaging people through meeting them where they're at. So we support like a wide range of harm reduction and overdose prevention strategies. I'm sure you're all familiar with our naloxone work, our fentanyl test strips. We have been working on the sort of expanding access to mobile addiction services, which have been great. So often people are reluctant to access or use traditional medical settings, and we've had a lot of participation in our mobile services because they're available to people. They're sort of non-judgmental, meet people out where they're at and help meet medical and substance use treatment needs. So those have been tremendous. We're excited to be supporting Safe Spot, which does supervised overdose spotting. It's just really great. As you, I'm sure you're aware, being that, I hear that you look closely at the data, that most people die at home alone, right? There's not somebody, they're alone. There's not somebody necessarily there to administer the naloxone for all the naloxone in the world. If somebody's alone, that you can't save them. So the Safe Spot is available for people to call so that there's somebody there listening. If the person becomes unresponsive, there's a plan of action of calling 911 or calling a neighbor or whatever the plan is with that individual and their. This is sort of it's an exciting model because otherwise we for years we weren't sure how to reach into sort of these situations where people are alone, especially in even rural areas or areas where it's hard to respond quickly, but or to be present. And certainly the response is still important in an emergency, but they have responded. They've had the opportunity to, through this service, they've detected and responded to 23 overdoses so far. So that's been a growing service that we're excited to be supporting. We also have been funding more and more permanent low threshold housing, where that you don't have to have, you're not required to not use substances to live there, to have like a housing first model that also has evidence for supporting people long-term on their path. So we're investing more and more in low threshold housing and really trying to get people housed. We're aware of just the issue of encampment and homelessness around the state that is challenging. We want to support positive engagement with folks and try as much as possible to promote low threshold housing. As far as treatment, we have a full continuum of treatment services that we support through licensure and as we mentioned, payer of last resort policy and other funding. As you're aware, we have acute care inpatient, residential outpatient, opiate treatment, OBAT, and specific for youth and young adults and families. We have 500 treatment programs around the state and 6,475 beds that are licensed and regulated by BSAS, so a large system in the Commonwealth. And some highlights we wanted to elevate are just the increasing access to medications for opiate use disorder that we've experienced. We can see in our data over time, just the numbers of the reach that this has had in the Commonwealth really has expanded. And I believe that the reduction in deaths is partially attributable to this, that they're really just increasing access for people with opioid use disorder to evidence-based practices like access to medications for opioid use disorder that really have made a difference. We're also now funding 15 hospitals, and I think I've come to this meeting to talk about this project in the past, but we have 15 contract hospitals and hospital groups, but it reaches 24 hospitals in the state because many are in large sort of hospital organizations. And we're funding bridge clinics and addiction consult service. So as people come through the hospital, they can meet with an addiction expert and really get support around engagement in treatment and linkage to care, or meet them where they're at as far as their needs, but really getting evidence-based attention to their addiction while they're there, which doesn't always happen. So it's been tremendous. We now have a learning community among the care providers in these hospitals around the state, and others are joining and really increasing the quality of care and access to care at this crucial touch point. We see it's available in our the dashboard that I showed earlier includes emergency department visits, so you can see the substance use related emergency department numbers locally and as I said, at the county or town or statewide level, and you can see what is the profile of emergency department visits related to opioids or alcohol and other substances, and there's just still so much demand at the hospital for these services. We also partner with in the state related to the behavioral health workforce that it's so important to have a strong workforce to provide these services. We license alcohol and drug counselors at BSAS. And we are in the process, as you all may be aware, there was last year, a large comprehensive substance use bill that included licensure for recovery coach. So it's transitioning from a sort of independent certification to a state license. So we're in the process of developing these regulations. We're also updating the LADAC regulations. So we encourage that there will be opportunities for public comment or as part of the standard regulatory process. There there's opportunity for a participation in that is when in the public comment period, if that interests you. We also within the workforce we were able to use ARPA funds for some great paid internships and other workforce development programming that was successful. We had a paid internship program that engaged 204 substance use and addictions focused interns across 8 organizations. So really boosting exposure and experience with substance use treatment and care. And of those, 35 transitions into permanent positions. So we've had the opportunity to participate in some great successful workforce development initiatives. As far as our recovery, again, I'm sure that you're very familiar that we have peer recovery support centers, recovery coach training, as well as statewide education and training and advocacy around the state related to recovery support. So we have now, it's been increasing over the years, 39 peer recovery support centers statewide, which have just been tremendous hubs locally for recovery support and a great variety of ways locally, how they're peer-led centers that are engaged in their communities and responsive to local need. We also have a recovery education collaborative, which runs a lot of the recovery coach training and other peer trainings cross domains. So there's a collaborative of organizations that lead that peer and recovery coach training. And as I mentioned, we're developing regs. So another thing we're working on is pathways for students like within schools of social work, for example, to get some of that training. So when they graduate, they have more substance use related education, can get their license, can sort of in addition to their social work licensure, be eligible for example, LADAC. So a lot of work happening, developing the workforce and training peers. Obviously, we are, it's so important to have peers in this work, and we provide robust education for and support for that workforce. We have a new community engagement and equity team at BSAS, which has been tremendous. They meet with people around the state. This is our team right here. They're really now like the face of BSAS in the community, trying to really establish relationships, meet with individuals and organizations around the state who are trying to, be part of the work. Lots of community based organizations doing the work, and they have we're developing lots of systems and infrastructures for people to engage with us in the work, including some development, some seed funding. We had a grant program called Redefining Community Wellness, which is currently operating and provides support to BIPOC-led organizations to in the community doing this work, and as well as a program called Collective Uplift, which is doing leadership and organizational development. And this team hosts regular community office hours, so people can come and join and learn about opportunities in the state, resources that are available. How can they? It used to be just difficult to access this information and to partner with BSAS, but this team has really developed methods and communication channels to work with us and be part of the work of BSAS and the state. We are launching, and you may have seen the announcements. If not, we're happy to share that we have this living expertise advisory pool. So the vast network that's already starting to form, people can join LEAP and then be part of our advisory pool. This can be professional expertise as well as lived experience with substance use. In some way, you can sign up to be in LEAP, and we can then access this group as in terms of helping to advise BSAS. So it's really trying to set up systems for community engagement, which we're excited about. With the ORF funding, we have partnered with RISE Massachusetts, and for part of our distribution of the funds, hope that you've all seen these, that we've had some funding opportunities through what's called Mosaic at RISE Massachusetts. We believe you're familiar with what the remediation funds, but we have 60% of all the total pot comes in incrementally to the state, and we distributed as I described earlier, and we've had a series of listening sessions and partner with Mosaic. Mosaic has done we want to make the funding more available. Often people ask, how can I access opiate remediation funds, and how are they available? We're working through RISE to do some of this grant making, just easier than trying to contract directly with the state agency, right? We used RISE, which is in many ways like a foundation. They did a series of community-based opioid response grants. They did a municipal matching grant process related to local remediation funding and matching and supporting work that's funded on that. And they recently had open a family resilience. There's been a lot of feedback and interest in supporting families impacted by the opiate crisis, that they're working on a grant program to that. And some of these will repeat again, right? We've had cycles of these. There will be more future opportunities to access the state pool of remediation funds. Trying to keep moving so we're not taking too long here. If I'm taking too long, you can let me know, but we're getting there. So we also, because I referenced this, we saw this earlier from the dashboard, that we track the drug supply pretty closely with our partners at Brandeis University. We're doing drug checking. They use really just trash and a lot of detritus from substance use that can be tested. They also work with some local police departments on samples that they have in their lockups that can then be available for testing. So we do quite a bit of drug checking around the state in terms of testing what's in the supply for public health purposes, and such as making fact sheets like this one, that what we're seeing in the supply, what is the impact, how does it impact our overdose response, what does it mean that these substances are in the drug supply, as far as how does it impact healthcare and addiction treatment and people's experience, and when you're observing somebody and their behavior is different than you expect, and how often it's something in the drug supply, right? So there's a lot of fact sheets available in the Brandeis web pages. We call it the Massachusetts Drug Supply Stream. They also have a website called Drug Check. I think that's what it's called. That you can see the results of the testing, that it's all posted so people can see locally what are what's in the supply from the testing. We try to put out also like evidence, science-based information. For example, because xylazine is not an opioid, there's a lot in the news about xylazine not being responsive to naloxone, which is true, but it's usually combined with fentanyl. It's not, people are not sort of taking it on its own, right? It's a contaminant of sort of the opioid drug supply, such that you should still always administer naloxone, which will work on the opioids and restore breathing, even though someone may be less responsive with the xylazine in the supply. So we want to reiterate the messages related to how to respond based on these trends. I mean, as we know, the drug supply is very chaotic. It's always changing. There's sort of new things that we're always, which I'll jump to this, that we're always detecting. There's something called BTMPS, which has been present quite a bit. It's erratic. Medetomidine, another veterinary medication that is now often in supply and also can really be damaging to people and impact their care in terms of the overdose response and just their impacting health and wounds and such as with xylazine. So really we need to in many ways pivot our care accordingly, but we are tracking these trends through our sort of public health oriented drug checking work. And as DA Ryan mentioned in the beginning about the use of stimulants, and it's true that historically there was not a lot of access to treatment specifically for crack cocaine use in the same way as with alcohol or opioids. And but now we have been expanding. We have a few programs called the START clinics, which has a model, which I hope you've heard about, which is a stimulant treatment recovery team that is stimulant specific. And we are also, our CSS programs are, and others do it now. We've pushed a lot of sort of direct treatment for stimulants, access to care for people who use stimulants, really sort of addressing that gap from the past. I do want to mention as far as alcohol, I know this is opiate task force, but as part of this, we're saying alcohol use is on the rise. And this is, again, emergency department trends. This, as I mentioned from our dashboard, we have emergency department visits on there that you can peruse. This is showing that substance-related ER visits, this is a statewide, by substance, you can look at it in different ways and just seeing the increases in alcohol-related emergency department visits. So we do have training and technical assistance available. We are promoting like with opioids, we've had medications for opioid use disorder, which have helped. As far as alcohol, there's been medications, but we're really that the evidence and science related to that and work on also a medication-based support for alcohol use disorder is growing. So we have more training, technical assistance related support to both inpatient and outpatient care for alcohol use disorder. So we're really looking at this, and also just the evidence coming forward related to the connections with alcohol and other chronic disease and cancer, and really seeing that we need to have better information for the public about the impact of alcohol on health in general, right? There's alcohol use disorder and there's need for treatment, and there's also just the health messages and information needed related to alcohol, which we're beginning to look at more. So that is my last slide. I'd say, and that happy to answer any questions, and thank you for your attention.
Sarah, thank you so much. I think what we're going to do is people can certainly put questions in the chat, but we'll otherwise hold questions to the end. So thank you, Sarah. That was great information. As promised, we're going to have Cassie join us to talk about the impact of opioid epidemic on older adults and how we can really be best supporting them. Cassie Kramer oversees the Older Adult Behavioral Health Network at the Massachusetts Association for Mental Health, where she brings over a decade of experience supporting at-risk older adults who are living in the community. She did work that we are very familiar with, having handled those cases as an elder protective service worker, as a clinician on one of the state's first behavioral outreach teams for aging populations, She is a certified peer specialist, has a background in peer support, aging, and cross-disability advocacy. She is the co-chair of the Older Adults Behavioral Health Collaborative, and she leads the Massachusetts Hoarding Resource Network, where she advocates for what everyone knows are really critical statewide behavioral health, peer, and wellness supports to help people age in place. And I point out that Middlesex County, we are happy that Massachusetts has a pretty high number of people aging in place anyway. That number is 10% higher in Middlesex County than in the rest of the state. Cassie has a master's in social work from Simmons and an advanced graduate certificate in expressive arts. So Cassie, thank you.
Hi, thanks so much. That was a really fantastic presentation this morning. Great information. I have a brief slide deck, but I really want to save a lot of time for discussion. I should say, with the Older Adult Behavioral Health Network, we do have monthly meetings. They're held virtually the second Friday of the month, and that is a really great opportunity. Let's chat. We would love to have people talking about this task force, about models like HOPE. There's a lot of interest among aging providers in learning more. But first, the good news, I think people have a lot of negative associations with aging, but actually there is kind of a bell curve in terms of our happiness throughout our life. And research suggests that we gain wisdom and resilience as we age. Actually, an interesting data point is that even though older adults were the highest at risk of serious illness during COVID, they were the least, they expressed like the least degrees of anxiety. So this is all positive news. The flip side is, though, while 1 in 4 older adults experience behavioral health conditions, less than 33% receive treatment, and that's the lowest of any age group. There's higher rates of stigma, about receiving treatment. There are a lot of different barriers, which I'll get into. We went over, some of the statistics earlier, so I'm not gonna repeat that. It's in the slide deck, which I can get a copy to you. So some of those treatment barriers, there's ageism among providers, and older adults are screened for substance use at lower rates, isolation, lack of transportation, co-occurring cognitive conditions, so difficulty managing medical care, physical impairment, difficulty leaving the home, especially in winters. We don't always have, accessible sidewalks, siloed service systems. And these are things we really aim to change with the Older Adult Behavioral Health Network. And then, most significantly, really the lack of specialized supports for older adults and supports that are accessible, often meaning in the home. And there are also increased risks of harm among older adults when they're using substances and opioids. But I also want to point out that most older adults who use opioids do so with a prescription. And despite the risks, these prescriptions can induce significantly improved quality of life for many older adults, especially those coping with chronic pain or illness. But there are increased risks associated with use as we age, frailty and falls being a big one. As we age, we have metabolic changes that impact how drugs impact us, physiological changes. I think that the estimates of overdose deaths are actually likely underestimated for older adults due to co-occurring physical conditions that can mask the cause of death. There's adverse drug interactions, uncoordinated care, and co-prescriptions with benzodiazepines. So what can we do? Increasing access. We can partner with aging services, and that is so important. We can host events at Councils on Aging. They have fantastic spaces. I'm thinking even in Cambridge and Middlesex, they have a roof deck. Like, these are great spaces. We should use them to host events and to reach older adults. There's the aging service access points. They have protective services. They also have home care and other services. And I think these are professionals that are really hungry for this information. There is such a changing demographic. I know when I started working with older adults, I don't know, about 20 years ago, we really weren't seeing hard drugs very often. And I really saw that shift in the number of referrals we were getting for people, using heroin or using other drugs. And I can tell you, I don't think the aging workforce is prepared and has the training and resources to respond to the shift in the demographic from what was called the greatest generation to the baby boomers. So in addition to doing that outreach and kind of cross hybridization, I also think it's important to deliver information directly to older adults. We partnered with AARP recently to host a webinar, Older Adults in Recovery, We Are Not Who We Used to Be. Again, educating older adults and providers about recovery centers and also that anti-stigma work of people sharing their story of substance use recovery. And investing in older adult specific supports is a really big one. So, we've seen, really, really amazing success stories when we have older adult peer specialists working with people that really understand kind of the challenges that we face as we age, and having specialized programming, everything from older adult shelter services. There's a really cool elder abuse shelter program that I put in the link there, because older adults, they just have different needs, and part of those access barriers is not having specialized services, and that need for those to be in home. So some different resources, aging service access points. I think it's a great idea if you're a provider or, in your community you can join a board. You can also reach out to the team to offer to host a training at a local aging service access point, just making sure that kind of cross hybridization, that networking is happening and we have tighter networks of care. Connecting with adult protective services. I do think there's a lot of myths and ideas that it's almost like punitive to file a protective services report. That's not the case. They're there to help. They're there to implement the least restrictive measures and can really put a lot of supports in place for people. Definitely the Mass Councils on Aging. It's really great to be connected with your local senior center. They host a lot of educational events and resource fairs, that sort of thing. And then investing in those programs, family caregiver support is a really excellent program. You can contact your local aging service access point to get connected. And the definition of caregiver is really broad and it encompasses older adults caring for a spouse to an adult child caring for an older adult. There's grandparents raising grandchildren and programs like chronic pain self-management. There's also some really stellar examples of specialized programs within hospital systems. The one I'm most familiar with being the Cambridge Health Alliance geriatric psychiatry program, and they even have a house calls program. It's an incredible program where they can actually deliver in-home primary care. And I'm going to stop sharing my screen because I really wanted to leave room for discussion and questions, or maybe we have the next presentation. I don't know, but yeah.
Sorry. All right, Cassie, you okay if we go to Chris and Karen and then we'll circle back? Okay,
Yeah.
good. All right, we're going to hear now from Chris Marr and Karen Pugh. And Chris is the Director of Security and Public Safety at Lowell Community Health Center. But just as importantly, he leads the Strategic Emergency Response and Mobile Addiction Treatment Unit initiative. And, one of the things we always want to be talking about here are changes and innovations and things that make things better. And I first knew Chris when he was a trooper on the state police, and he did nearly 15 years of service there. He brings a rare frontline experience to dealing with this crisis. Rooted in his perspective is rooted not only in law enforcement, but in deep personal experience with long-term recovery. And what he's designed really stands at the intersection of public safety and public health. Because Chris helped to design and operationalize the Lowell Community Health Center's Community Care in Reach Mobile Addiction Treatment Center, which you just saw a photo of. And up in Lowell, it serves thousands of unhoused and high-risk individuals across the city. And under his leadership, that unit has really become a trusted presence on the street. It offers trauma-informed engagement for folks, peer-led support, and a direct pathway to treatment and care. And Karen has worked on that program as well and is joining him to just really talk about something that's different. It fits a very urban area and has really just become part of the city now. So I'm happy to turn it over to Chris and Karen.
Awesome. Thank you so much, Deanne. I appreciate it. And thank you so much for everyone who's presented a lot of really, really good info and mission aligned stuff for what we're trying to do up here. Karen sent me her bio late last week and I forgot to forward it. So I'm going to give Karen's bio because she's going to do the first slide anyway. So Karen's one of my best friends here, first of all. That's the most important thing. But Karen Pugh is a seasoned healthcare leader with over 20 years of experience driving strategic operations, designing and implementing innovative community-centered programs and integrated care initiatives at Lowell Community Health Center. As Senior Director of Patient Services, she has led cross-functional teams and implemented innovative programs that have advanced healthcare equity, equality, and community-based well-being. Karen holds a BS in Community Health Education from UMass Lowell and has completed advanced training in healthcare leadership and quality improvement. She's also deeply committed to civic engagement and health equity at the community level. And this was Karen's long before I had anything to do with it. So we'll go to the first slide and Karen will tell you a little bit about our program out here. Thanks so much, Karen.
Mm-hmm. Morning, everybody. Is that gonna, oh, there we go. Okay, so we're just gonna quickly go through, I'm not gonna sort of read through all the bullets, you guys will get the presentation, but this has been a long-term vision of Lowell Community Health Center and some of our partners, the city, and some of the other substance use serving organizations that we partner with. And with the generosity of a grant through the Department of Public Health, BSAS, and the Kraft Family Foundation, we were able to finally bring our Care and Reach mobile unit to fruition. So what we're really looking to accomplish, we've been in operation since I think April. Really, we kind of tried to start off slow, and although we felt like we had a good sense of what the community needed, we really wanted to make sure that we evaluated and took some time to get to know the community, make sure that we were in the right places at the right time. And so, really through talking with the City of Lowell's homelessness provider team, there's a provider group that gets together weekly, talking to some of our unhoused people that we are working with other programs throughout the health center. We really kind of landed on a couple of places. So if you're familiar with Lowell, we're located at one of our most popular parks, the South Common, where a good number of unhoused individuals work. And then we're located at the very, very old courthouse over by the health center. And although we're close to the health center, we know that individuals that are accessing our services, that are accessing mobile services, just aren't comfortable coming to our bricks and mortar here at the health center, which makes this mobile unit all the more important. So really what we're trying to accomplish is doing some very low barrier assessment, screening, education. We're providing lots of harm reduction with, just a few examples being the xylazine fentanyl test strips, and education around substances that are in the community. As Sarah pointed out during her presentation, we utilize those resources from BSAS to be able to educate our community. We're doing naloxone distribution. We recently introduced rapid HIV screening, and we're starting to provide some nursing care services around immunization and wound care, which has been super important to our community because we know that those patients in need just are not making it here to the health center. So yeah, it's around just making sure that all of our services are offered with trauma-informed care in mind, and our teams consist of, we have a LADAC that is overseeing the day-to-day operations on the unit, along with recovery coaches, community health workers, nurses. We have overdose education, Narcan distribution, educators, and a member of Chris's team that's been cross-trained in safety and security, as well as community health work, which has been sort of like a really key piece to the work that's being done. And all with a goal of intentionally helping to bridge patients back to the health center, and getting them the more extensive care and support that they need around prevention, whether that's MOUD services or primary care treatment for some of their, chronic mental health, or some of their chronic physical health. So, the team, while they're out there, an example would be someone might present, we're trying to find out, are they patients of the health center? Do they have a primary care provider? Are they insured? If they are a patient of ours, do they have pending orders? Are they picking up their prescriptions? How can we help to create those bridges for them? And if they're not, then how can we get them established into care and serve services that they need? So really, as I think has been the theme throughout all of these presentations, is all about partnerships. This didn't just happen. Being able to be part of the homelessness provider group, and then also our intentional partnerships with the city and with organizations like Riverbend and the Middlesex Shelter, and a variety of the co-op. I think the list could go on and on. Elliott Church. We were able to really put forth a great proposal to be able to have our unit out in the community. We're out there 4 days a week, and currently we're at 2 separate locations. Sometimes it changes based on where we're seeing a need. So, we are in a system that we're intending to be able to pivot and to reach, if we see a spike in overdoses in a certain area, that we're able to sort of pick up our operations and go to that area and then address those needs. We've had the unit out more recently with the heat, making sure that we're just, building relationships, distributing cooling towels and water and snacks and sunscreen. And so we're really trying to sort of also, as we're building those relationships, provide some of those personal care supplies that people might need in order to stay safe in our community. And so, it's really, it has been a vision of mine for a long time, and I'm just thrilled that it's been really successful. Chris is going to talk through some of our true impact and what we've been able to do in the few short months that we've been open. But I look forward to any questions or further information folks would like after Chris. Thank you.
Thanks, Karen. Chris, back
Excellent.
to you.
Thanks, Karen. Good news. Chris talks fast. So I just wanted to be able to share some numbers with you. So we've only really been in true operations for a little over 3 months. So these are our March 24th to June 24th numbers. And again, it's important to know what Karen talked about is trust plus access equals impact. And this is an example of what our impact is. All of this is data driven. And the Kraft Foundation is great with being able to provide resources to assist with that data and the evaluation of that data. So in the 3 months that we've been out there, we've had 625 engagements. And that's, again, like Karen said, that's folks who aren't going to cross our bridges and walk into our health center. So that's 625 people that we would not have been able to engage with as a community health center otherwise. And of that 625, there are more than 50 referrals. So, that's averaging about 13, 14 every month, which based on the amount of time we're out there, that's a really high number. And that's people who have made it across the bridge from, the outreach van to whatever services those are. Whether it be our OBAP services or, into a treatment facility. And again, just to touch on, every number here is a relationship earned. That number that you spoke about earlier about, every person that overdoses has 10 people, or more. Some of the folks that we're dealing with out there that we're able to assist with this mobile addiction treatment program don't have any. How much more heartbreaking is it the person that doesn't have 10? And we've seen through our experience and through our work here that we're really able to make actual change to these folks. Because again, they're not just statistics. Everyone represents somebody who trusted us. And we, in addition to these partnerships that we have with local providers, we sit on these meetings with the Kraft Foundation. They have, I think, like 18 or something vans out in the New England area now. And we talk about these things. We had a really good training the other day in which the guru of this work said that he has studied all the numbers. He's looked at everything when it comes to this work, different models, different locations, different staff, and only one thing was proven to make any difference. And it's seeing the same face on the unit and the same face when they walk into the health center. In all his years of doing this work, it's the only thing that has made any difference. So we really have been privileged to be able to have the ability to be able to build that bridge, but be standing on both sides of it with the same faces and the same trauma-informed care. We talk about that a lot, trauma-informed care, which one of the biggest tenets of it, we've heard it 3 times in this meeting today, meeting people where they're at. And Karen said one of the most important things, we can't assume we know where that is, no matter how dug into this work we are. So we really try to keep this program consumer informed, patient informed. What do you need? What are we doing that doesn't matter to you? And what do you really need that we're not doing? And not assuming that we know better because of all the introductions that we give ourselves on meetings like this, But again, the coordinated response model, we've been able to have referrals. We track those referrals. We make sure that, we don't just make the referral and then say next at the van, we make sure that we follow these things through. Our integrated care folks here are amazing and always have been. And now we've just provided them a new resource to be able to to have their reach extend even further. So this is out there for us. This is working. Partnerships are the most important thing. The 2 biggest pitfalls in partnerships are us against them. And we really try to break that stigma. And I can say that, based on my bio, I have experience in law enforcement and I'm in long-term recovery. I am us and them, and it's my life's work to try to make sure that we can all get in that space together. And then the other thing is, anytime we're in these partnerships and anytime we're doing any of this community, there's such a delusion that there's $1 on the table and we're all fighting for it. And we can really stop collaboration dead in its tracks, when we're in that space. So just encouraging everybody, we're all in this together and we're all trying to do the same thing, is super important to us. And again, I love on the, just to finish, I love on the BSAS slides. The first one, they had the little signs, and the first one said, stigma hurts, treatment works. Isn't that the truth? But then the other one was even better. It said, believe in miracles. So I'll leave you with, at Lowell Community Health Center, we believe in miracles, and this community outreach program is one of them. Thanks.
Thank you, Chris. All right, questions for any of our speakers? You can raise your physical hand or put them in the chat. I'll try to keep an eye on everything. Questions, comments? Oh, let me check the chat. All right, Sarah's already answered one of the questions.
I
in
can
the chat.
respond to the other comment, the one before that about municipal funding. I think there is a provision that allows municipalities to transfer their funds to the state pot if they prefer to do that. So that is something that exists, that, you know, there is guidance related to how that funding can be, you know, there's the subdivision agreement on how those funds can be spent by municipalities, and sometimes if they don't want to do that, they can transfer it to the state pot, so there is an opportunity for that. We are working on, developing, and I was just looking on the RISE, we're in the process of setting up our municipal TA system with RISE Massachusetts, so and we're putting out more guidance like you described, like is commented on here. Like, okay, here's some things you can do, things we would recommend or not recommend, just to give another layer of suggestions and support for municipalities. So we are developing through the range of technical assistance that we're offering through RISE Mass.
Maria, I saw your question, is the statistic for 60 plus across all the users. I'm sorry, which statistic did you ask me about? Maybe if Maria's still here. Okay. Track her down. All right. Any other questions, comments? All right. We will, to the question of whether we'll send out the recording, we will do that and make the slide decks and all of that available to people. So the other thing that you may have seen yesterday, I guess people should keep an eye on, the president signed a bill yesterday changing the classification of fentanyl to a class 1 drug. There are some very substantial penalties included in that bill. And they are mandatory penalties. I know I haven't had a chance to read the whole bill yet. But at least the overriding sense is the mandatory penalties start at 10 years in federal prison. So obviously we don't have the federal government taking all of those cases, but in the appropriate cases, it does give a different remedy. All right, thank you all for being here. Remember, if there's things that we can do, whether it be Narcans, testing strips, please let us know that. Anything that anybody wants to share that they are hosting or doing? No, I'm gonna take that as a no. All right, stay cool, everyone. We'll see you next month. Thank you, and thank you again to all of our presenters. That was great information. Thank you.